Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar, Six Misconceptions of Heart Valve Surgery. If I have yet to meet you, I'm the patient who started HeartValveSurgery.com nearly 20 years ago in 2006. The mission of our website is very simple. We want to educate and empower patients just like you. And this webinar, which has had over 700 registrations from patients in countries all over the world, was designed to support that mission. Now, throughout the webinar, you're going to be in what's known as listen only mode, but I encourage you to submit your questions in the control panel on your screen. And as we look at the agenda, I'll explain why that is. So for today, I'm going to introduce the featured speaker. We're going to talk about the top 6 misconceptions. We're going to have an interactive question and answers session, and then I'm going to ask you to complete a very quick 5-question survey. Now, as for our featured speaker, I am humbled and honored that he's taking time away from his very busy practice at Northwestern Medicine to be with us today. Who is he? Well, Dr. Chris Malasry is a cardiac surgeon at Northwestern Medicine in Chicago, Illinois. He is the co-director of the Heart Valve Center, Bicuspid Aortic Valve Clinic, Thoracic Aortic Surgery Program, the Ross Procedure Program, and the Mar-Fan Clinic. He's not just going to educate patients here today, he's also a professor of cardiac surgery at the Feinberg School of Medicine. During his extraordinary career, Dr. Malasry has not performed 100 or 300 or 500 or 1,000 heart valve procedures. He's performed over 1,500 heart valve operations. And I've been thankful to learn a lot about his practice over the years. And what I know is, in particular, he specializes in minimally invasive techniques to help patients recover faster and get back to their normal life expectancy. Now, when it comes to Dr. Malasry, I want to tell you a couple of things. The first one is he has been a supporter of the HeartValveSurgery.com community for nearly 15 years. Chris, you might remember this back in 2011. You and we didn't have any gray hairs, right? Things have changed over the years, but one thing has not. Your commitment to educating our patients in our community, whether it's through videos or through articles, is unparalleled. I estimate that you have helped over 250,000 people around the world learn about their disease. But it's not just the education. When it comes to the clinical care, what you see in front of you right now are the smiling faces of patients who went to Dr. Malasry and his team at Northwestern Medicine and got extraordinary outcomes. Whether it's Joe or whether it's Jim or Tom Tanser or Jesse McBride, these are all folks who are living great lives after their heart valve therapies. In particular, I was at a wedding not too long ago in San Diego where I came across Linda Pearson, who's one of Dr. Malasry's upcoming aortic aneurysm patients. If you have any interest in learning more about what patients say about Dr. Malasry, you can go and see his patient reviews at HeartValveSurgery.com. Chris, I don't mean to make you blush, but I know that there's some congratulations in order here because this is the 20th anniversary of the Bloom Cardiovascular Institute at Northwestern Medicine. Wanted to congratulate you and your team on that. I was fortunate to spend some time with you earlier this year. And there's one other great thing I know you just accomplished, which was your and your team's completion of the 100th Ross procedure at Northwestern Medicine with 0.0% in-hospital mortality. So Dr. Malasry, I can't thank you enough for being here on behalf of all the patients on the line. Welcome to the webinar, and let's welcome Dr. Chris Malasry.
Thank you very much, Adam. I'm truly humbled to be part of this organization. I think we bring so much to patients because it really is about the patients. And you come to me when you're having problems with your health. So that's a time of bad news. And I love it when we get positive feedback after a successful operation. And I like seeing all these thank you notes from the patients that we've treated through almost 20 years.
Dr. Mlasery, in terms of what patients know or think they know, that's the epicenter of this conversation. So let's go ahead and talk about the 6 misconceptions of heart valve surgery. You want to start with the first one?
Yeah, I think the first misconception is that patients should be concerned about mortality and pain after heart valve surgery. So when we talk about mortality being risk of death. Next, the while the risk of death is real after open heart surgery, meaning it's not 0%, it is a lot lower than patients think. STS, which is our Society of Thoracic Surgeons, publishes national data on outcomes after valve surgery. And most people are impressed to find that we can do an operation such as a mitral valve repair electively with an operative mortality less than 1%. And other valves such as aortic valve replacement, certainly coronary artery bypass grafting can be done with a risk of about 1% to 2% to your life. So it's a lot less than people think and has gotten a lot better over the years. So in short, you shouldn't be worried about these things because that's my job. My job is to worry about how to get the patient the best outcomes possible. And it's not just risk of death, it's also recovery. And we've made great strides through the years on making sure the patient has a successful, quick recovery after surgery, because that's a big deal for young patients who are still working. They've got to take care of their kids. Maybe they've got elderly patients they're taking care of. One question I often get is, how long do I have to be off of work? How long am I out of commission after valve surgery? And that time has gotten less and less. I think with programs such as enhanced recovery after cardiac surgery, or ERAS cardiac for short, where we use specialized techniques with anesthesia, such as spinal blocks that's used to minimize pain after surgery, getting patients carbo-loaded afterwards to minimize the risk of low glucose after surgery, getting the patients off the breathing machine as soon as possible, sometimes in the operating room after valve surgery, specialized techniques to do closure of the sternum, that's the breastbone in front of the heart, and avoiding opioids as much as possible. We certainly don't want patients in pain, but we've got many options that can avoid opioids that we can get patients out earlier. So next slide. This is some of the data from our national society showing outcomes after aortic valve replacement. So a very common procedure for aortic stenosis, both for bicuspids and normal valves. And what we found in national data sets all across the country, that your risk of death from this operation runs at about 1.5%. And that's pretty low. Specialized centers can do it with less, but this is what you can expect across the country. So that's pretty impressive. Next slide. We have shown that patients may need only 3 days of recovery in the hospital after valve surgery. So that's pretty cool. Long gone are the days where patients have to spend weeks in the hospital recovering. We like patients that go home early. 3 days is pretty quick. So for instance, you have your operation on Friday, you could go home as early as Monday and not miss a beat. There's still recovery after surgery, depending on what sort of incision you get. That could be anywhere from 2 to 6 weeks of recovery at home, during which time we do want you up walking around, but maybe no golf, no tennis, no high-risk skiing during that time.
And Dr. Mlasery, before we go on to the next misconception, you mentioned the ERAS, the Enhanced Recovery After Cardiac Surgery. I went to the leadership meeting in Austin last year. You were there, and there were I would say about 40 leaders in the space of recovery, but it wasn't like there were 1,000 people there. And I'm curious to know, is ERAS in particular followed by all of the hospitals out there, or do different cardiac centers use different protocols to help patients start the recovery and recover faster?
Yeah, ERAS can be difficult to implement because it's not just one intervention that we use, but multiple interventions. So it's the whole package of things that we can offer for patients and get patients out in 3 days, for instance, and back to work earlier. So not all centers will be able to implement the same package, but societies such as ERAS Cardiac have certainly made it a lot easier for all centers to adopt this practice.
Great. Thanks so much.
Second misconception I want to address is that heart valve replacement is better than a heart valve repair. So that's a big, big misconception. Next slide. We sometimes think that parts in the body are like parts in a car. So for instance, the fuel injector is broken, that you just take it out and give you a brand new fuel injector. But it actually turns out that your own tissue is the best tissue that you can have. So we can repair your valve and leave you with your own valve. That's going to be better than an artificial valve. And please remember that artificial valves come in two varieties. One is a mechanical valve, so it's made out of high-grade carbon. The other is a tissue valve or a biologic valve, and that's made out of animal parts, so either cow or pig. So that's typical for an artificial valve. Now, you may encounter options for repair versus replacement in mitral valve repair. I think that is the most common area where repair is done over replacement. And the data for that is very good, that you're going to do better with a repaired mitral valve. We have more and more data that valve repair for the aortic position, with or without valve-sparing aortic replacement, is also superior to an artificial valve. We've shown that with our data at Northwestern. We've done more than 300 valve-sparing aortic root replacements, and we've demonstrated superiority for aortic valve repair over valve replacement. And I'd also like to address the Ross procedure. While strictly this is not a valve repair, we are using your own parts. So we take your diseased aortic valve, we give that to the pathologist, and we replace it with your own pulmonary valve. So it is your own parts. I think the next one is a video.
I think you have some.
Yeah, the next one is the video, if I remember. So here is a cartoon of the heart that is animated. So a patient has aortic valve disease, usually aortic stenosis, and we take that out and we use the patient's own pulmonary valve and use that as a replacement part. We take a pulmonary valve that is frozen. It is a human valve. We have that available and available to us right away for every case, and we use that to take the position of your pulmonary valve. So you hear terms like pulmonary autograft. That is your pulmonary valve used in the aortic position. The homograft is the frozen human valve we put in the pulmonary position. So it is a translocation procedure. That's how the government bills it, meaning that it's a little bit like musical chairs. Diseased valve goes out, pulmonary valve gets slid over, and the frozen pulmonary valve gets moved in. There's also data, going back to the other slide, showing that that shows that the Ross procedure is better than a replacement. This is a study from England by a world-renowned cardiac surgeon who has been knighted. His name is Magdi Yaqub. He showed that not only is the Ross procedure better than a replacement valve, but it also restores normal life expectancy. So the curves there on the right are Ross procedure in a normal population. Those curves exist right on top of each other. And if you're good at looking at graphs, you also notice that the percentage survival there is impressive at 95% at 12 years. So the Ross procedure has been demonstrated to be better than replacement, and also your best chance of returning to normal life expectancy, as in patient population that doesn't have valve disease at all.
Yeah, and for the patients on the line who may have an aortic form of aortic valve disease and are considering this very important consideration of a replacement versus a repair, Ross procedure. So everybody knows I actually had a Ross procedure done nearly 20 years ago. I wanted to retain my own tissue in the aortic position. And it has been, like I said, nearly 20 years. I have had no reoperation, no form of any kind of intervention, and I have not been taking any type of medication like Coumadin throughout the last 19 years. So if you have any questions about that, don't hesitate to contact me. I can help from a patient perspective, share my experience. But Dr. Malaisri, congratulations again to you and your team for all the work you've been doing on the Ross procedure.
Thank you very much. Third misconception, a full sternotomy is the only incision that can be used to fix heart valves. So we can do minimally invasive cardiac surgery, MICS for short, MICS, and that's a subspecialty of cardiac surgery. And that's where we do heart surgery. It's still open heart surgery through an incision that does not involve a complete sternotomy. So sternotomy is dividing the breastbone, that's the bone in front of your heart. And these procedures have been done more than 15 years, and the adoption has increased. So for instance, if you need a mitral valve repair or an aortic valve replacement, then I would offer you a incision in between the ribs on the right side. We call that a right thoracotomy, right anterior mini thoracotomy, or RAM-T for short, with or without a robot. So all these tools exist for us in order to spare you from a sternotomy. We found that with that, the patients do have faster recovery, less physical trauma, and very quick return to work afterwards. So for instance, if you have an aortic valve replacement mini thoracotomy with me, I would say that you'd only need about 2 weeks of recovery at home, and then you're free to go play golf and play tennis after that. So I think that's really impressive for younger patients who want to get back to their normal activity. Now, it's not a procedure that is suitable for every patient. And there are things that we think about when we think about minimally invasive cardiac surgery versus full sternotomy. I think the biggest one is whether or not the patient has other cardiac disease that should be treated at the same time. MICS is great for isolated valves, but if the patient also needs bypass grafting for coronary artery disease, additional valve work other than the index valve, or atrial fibrillation, that these patients, I think, should get a full sternotomy and a good chance at repair of everything at one time. So this is the biggest group of patients. We always default to the safest and most efficacious operation for the patient. I think that trumps the minimally invasive approach. It's better to get a perfect heart operation than to get minimally invasive heart surgery just because it's minimally invasive. Oh, and these are drawings for approaches. You'll see that both of them avoid the full sternotomy. On one side is a mini thoracotomy, that's incision between the ribs. We don't actually divide the breastbone. You also hear about a mini sternotomy where we divide only part of the sternum, about half of it, so leaving the other half completely intact. Here's some data on minimally invasive heart surgery that we recently presented. And this is one operation where we'll do both a valve and an aneurysm. And we looked at our outcomes, which have been great. Most of our cases patients who have aortic valve disease, who also need an aneurysm repair, underwent a partial sternotomy or mini sternotomy for this. And this can be done with very low risk and quicker return to home and recovery.
Yeah, and Dr. Malasry, I want to thank you for stressing safety amongst all considerations, because I do get several emails and calls from patients who are so focused on getting a minimally invasive approach that sometimes we have blinders on our eyes. We don't look at the big picture. So thank you for ensuring that it's always, even though there are the benefits of faster recovery and smaller incisions, for ensuring that safety is first and foremost amongst your patients. So thank you so much for that.
Misconception number 4, an excellent heart valve surgery will permanently fix the patient's heart valve defect. Well, while we wish we can give you a money-back guarantee on open heart surgery, we can't do that. Even the most durable valves we can give you, which is a mechanical valve or a valve repair, may fail in the future. And the reason for that is patients are living longer and longer. So say, for instance, we operate on a patient, they're 20 years old. We would need 50 to 60 years of durability for them to get all the way to the end of their lifetime. While we certainly hope that, we can't guarantee it. I think some of the valve repairs have the best chance of offering that to patients. But there are some valves where we know will not last forever, and patients should expect to have a second valve procedure. And for those group of patients who receive a biologic valve, so an artificial biologic valve, either a pig or a cow valve, whether it's done with surgery or with transcatheter valve surgery, these absolutely have a lifetime to it. And they've been studied very closely. Tissue valves probably have a lifetime of about 10 to 15 years. So if you're a young patient, you're looking at 30 or 40 years ahead of you, then you should be planning on a second procedure for that. Doctors call that the lifetime management of valve disease. But for you, it means that you're going to need two procedures, and that takes a lot of thought. And there's options we can offer you. There's a menu of operations we give you in the first operation, and an even bigger menu of operations that we can give you for the second intervention. And next slide. One piece of data that highlights that is the issue with TAVR, TAVR, or transcatheter aortic valve replacement for short. That's a procedure where we deliver the valve through the groin. There is no incisions on the chest. And what we see over time is that failing TAVRs have increased almost exponentially. So the green and the blue line, particularly the green line, has gone up from 0% at 2012 or 0 cases to about 600 cases in 2023. So these TAVRs that are going in certainly are failing, and we're seeing more and more of those for reoperations. Next slide. Misconception number 5. Transcatheter devices will make open heart surgery irrelevant. I don't think so. So the previous slide with TAVI explants is a good point of that. TAVI valves that go in will fail over time if the patient lives long enough. And usually those patients will need a reoperation. While transcatheter valve replacement, or TAVR for short, has been of great benefit to our patients, more patients are now being treated with something. Almost 100,000 cases now, 2023, have been treated with TAVR. TAVR has made so many strides for our patients because more patients are being identified with valve disease and therefore treated with valve disease. Now, beyond TAVR, we also have transcatheter options for mitral valve and tricuspid valve. They're FDA approved, and also for pulmonary valves. So it's not just the aortic valve can be treated with transcatheter procedures. All the valves can be treated with that. But the question still remains, what is the durability? And we should expect probably as good as surgical aortic valve replacement for TAVI in terms of durability. But we're not quite sure yet. So I think data out to 10 years shows that TAVR is holding strong in terms of durability. So that's good. If you're older, then probably the TAVR valve is going to be the last valve you ever need. But there are things that we should think about. TAVI explant is certainly a consideration. But right now, we consider heart surgery as the gold standard by which we compare transcatheter valve replacement. This is just an editorial that me and my colleague, Dr. Medina, has written based on that data that you saw earlier. More and more TAVI explants are being performed in the United States, and these cases are complex. So that was our point. The risk of surgery for a TAVI explant is a lot higher than other open heart surgery, much higher than you would think. And although there's more cases coming to us, they're more complex as well.
Dr. Malaysia, I've got to ask you a question. I'm sure the patients might be wondering this. We saw, obviously an increase in the utility of the TAVR explant procedure. I'm curious, you and your team and all the teams, the cardiac surgeons out there, follow some of the guidelines for which procedures are best for which type of patients. Has there been any kind of adjustment to the guidelines given this increase of TAVR explants, or no, not yet? It's still kind of a wait and see.
Well, I think there was a great enthusiasm for TAVR as it been deployed across the country, and it is guideline recommendations that older patients over 65, that TAVR should definitely be considered. Now, the enthusiasm for TAVR has expanded to our younger patients, less than 65, where we really don't have a lot of data to support TAVR as an option for those patients. But there are some younger patients that would benefit from it, like high-risk patients who were not great candidates for open heart surgery. So I think the enthusiasm for younger patients has to be tempered because we do have great options for our younger patients in the form of open heart surgery, whether that's a Ross procedure, valve repair, valve replacement, minimally invasive cardiac surgery. We have so many options for our younger patients that they should consider more than just TAVR.
Great, thank you.
Misconception number 6, all cardiac centers offer patients the same heart valve therapies. Next slide. Well, there's several reasons that this isn't true. The first is that with more cases, super specialization does occur. And we all know that if the more that you do of something, the better you are at it. So if you're looking, if a surgeon is only doing several cases per year, that surgeon is not going to be as good as someone who does 10s, 20s, 30s, sometimes 100 of these complex procedures per year. So that just makes sense. But I think more importantly is that specialized centers are the centers that are developing these new innovative procedures. So for 20 years ago, when Adam and I started this, TAVR was a brand new procedure. And we were the first centers in the country to offer this operation procedure or patients all the way back in 2007. So it's the innovation in the clinical trials that we can offer patients that are the big difference for why you would want to go to specialized heart valve centers. So at Northwestern, we have over 10,000 participants in 100 clinical trials. I think we give as many options as possible for treatment for our patients with valve disease. Next one, let's see. Oh, this is some great imaging pictures from our 4D MR lab led by Michael Markle, who's also been with us for more than a decade, showing the flow through the aorta. And this is a completed Ross procedure that we had the pleasure of studying with 4D MR. And you can see the near perfect blood flow. You could just admire it with your own eyeballs. You don't need to be a scientist, although we have quantified all of the flow patterns here. Just with your own eyeballs, you can see that the flow is near perfect.
And Dr. Malasry, if it wasn't perfect, right here we see just a lot of laminar flow. What would be happening in this flow of, let's say, a valve that was bicuspid and it was having problems? What might the patients be seeing here?
Yeah, the flow would be off angle, so not in a straight line, sometimes directed to the wall of aorta, which we think is part of the reason that patients with bicuspid aortic valve also develop aneurysms. You'd see very vertical flow, so it would be a twisting pattern in the flow pattern in the aorta. And definitely the red sort of tells you there's a lot of red. That means the flow is very, very fast. It should be slow and smooth.
Great. And if anybody wants to learn more about 4D MRI, just type 4D MRI at the search bar at HeartValveSurgery.com. Dr. Markle was, we were lucky to spend some time with him, and he shared all about the work that you and your team are doing there at Northwestern with this new technology. So, Dr. Malasry, that got us through the misconceptions of the webinar, the 6 misconceptions. And now we have gotten a bunches of questions from our community, both here live and before the webinar. So let's go ahead and get into a rapid fire session here of questions and answers. The first one comes in all about teaching hospitals from Robert. And he asks a really great question that we've never covered here before, which is, at large teaching hospitals, how much of an open heart valve repair or replacement surgery is usually performed by the well-known lead surgeon, and how much by residents? What is the minimum level of lead surgeon involvement that is acceptable?
And I will answer that, but This is another misconception that a lot of patients have is that just because you have residents that the outcomes aren't good. It's actually it's totally opposite. Teaching hospitals have better outcomes than hospitals without residents, medical students. And you got to remember, one of our jobs as a professor of surgery is to train the next generation of doctors and for us heart surgeons. So the resident is never independent. This is the lead surgeon's case. And the lead surgeon is always there for the critical portion of the heart operation, which is well defined for us. And that's usually defined as the period of time that the patient is on the heart-lung machine. The heart-lung machine is the device we use to take over the function of the heart and the lungs that allow us to operate on the inside of the heart. That's why we call it open heart surgery. Now, you may ask, well, what do the residents do? Well, they'll assist during the critical part, and they will also open and close the incision.
Great. Thanks so much. I hope that helped you, Robert. Let's move over to Dan. Real important question about blood pressure. He says, prior to my aortic valve replacement for stenosis, my blood pressure was 110/70. Since the replacement, the BP has averaged 15 points higher on both measurements. Is this normal?
This is normal. And a quick lesson on physiology. So patients with aortic stenosis, that means that the valve is narrow and tight, so it's obstructing blood flow through the heart to the rest of the body. So in a diseased valve, that will reduce the blood pressure in most patients. Now, with a successful valve replacement, that obstruction is relieved, so the flow to the body is higher. So that means sometimes the blood pressure will be higher at the beginning and come down later as the body gets used to the normal flow. You'll need blood pressure medications occasionally. So for Dan, I would say take the win. This sounds like a successful valve replacement for you.
Great. And this question, Dr. Malasry, seems to be coming more and more frequently in my inbox, which is about this idea of moderate aortic stenosis, and you could, I'm sure, apply it to other forms of disease, moderate mitral regurgitation. Carol asks, my question is, why must you wait until aortic stenosis is at the severe stage and not replace or repair the valve at moderate stenosis?
Yeah, well, we certainly want to treat patients when they become symptomatic or when there's damage to the heart. We take a very close look at the echocardiograms, CTs, MRIs to make sure it's the appropriate time to make an intervention. We also don't want to break what's fixed, even if you will need the operation later. And for patients with moderate aortic stenosis, most patients don't have symptoms. There isn't any damage to the heart. We'd like to wait as long as possible before we give you an artificial heart valve. Because as soon as you get an artificial heart valve, then you'll have to contend with issues that arise with artificial heart valves. That's Coumadin for mechanical valves and a limited durability with tissue valves. So we want you to live with your own valve as long as possible and then replace it when we have to.
Great. And a question coming in from Dennis about valve selection, which you were just addressing. It's kind of a case study, Dr. Malasry. He says, I'm a 76-year-old man who walks 5 miles a day. He's asymptomatic, but he needs mitral valve AFib surgery. I want a mechanical valve as I don't want to have surgery again in my 80s. I've been on warfarin since 2006 with no issues. My local surgeon demands a biological valve and no debate was allowed. What does Dr. Malasry think?
Well, I think the debate is a worthy debate, and we have these debates in our doctor meetings as well. But for this case, I do agree with the local surgeon. At 76 years old, the durability for a tissue valve is pretty good. You're right, it can't beat the mechanical valve. The mechanical valve is made out of high-grade carbon. That's never going to break. But with a tissue valve at 76, there's a good chance that that's going to get you to the finish line. So I definitely agree with the local surgeon. The key feature here is that the surgeon is going to offer AFib surgery. So the patient has atrial fibrillation. They're going to offer an operation like the Mays procedure, which will eliminate atrial fibrillation afterwards. So this is pretty cool. So with the Mays procedure, there's about an 85% chance that AFib will be gone at 3 months. With the treatment of atrial fibrillation also goes the need for anticoagulation. So if the surgeon is going to do mitral valve surgery plus AFib surgery, and you will be free from atrial fibrillation at 3 months, that means you'd be off of Coumadin, then a tissue valve for you is a very attractive option.
Got it. And I understand that Northwestern has done a lot of work in terms of atrial fibrillation and the guidelines for open heart surgery when a patient is going in for some form of valvular disease or coronary artery. Is this a requirement now that the AFib is treated when a patient is having some form of open heart surgery?
Well, it's definitely a consideration. Guidelines say that should be done at the same time of valve surgery, and for one important reason, and it's not to get you off Coumadin. The reason to do atrial fibrillation surgery is to reduce your risk of stroke and subsequent death. So we've been able to show that very well, that if you do a proper AFib surgery with closure of the left atrial appendage, that definitely a reduction in stroke can result from that. And there is also an improvement of survival because the patient is not in atrial fibrillation.
Awesome. Thank you so much for that work that you and I know Dr. McCarthy has been doing in particular. This is a question we've never gotten before, but I'm sure it happens and it's a situation. Virginia asks, what can you do for a person allergic to contrast dye? I need a heart scan and possible valve repair / replacement.
Yeah, there's different types of adverse reactions to contrast dye. If it's a true allergy, then it can be difficult to manage. But most patients have a reaction to contrast dye that we can treat. So we can pre-medicate patients before they get the iodine contrast dye. Sometimes we have to admit the patients beforehand in order to get that done. Remember that this left heart cath is a same-day procedure. Usually you come in, you have it done, you go home the same day. But if we have to pre-medicate you, watch you afterwards, because it's necessary to get this heart study, then we'll do that for you.
Yeah, and now maybe we can touch on another real-time question coming in. Do all patients get an angiogram before heart valve surgery?
Right, there's other modalities to look at the coronary artery disease. So this left heart cath, you see all these squiggly lines, those are called coronary arteries. And the traditional way to look at that is to introduce a small catheter through your wrist and inject the contrast dye. Now, with the newer CT scans that I think a lot of patients have been through, that the resolution of these newer scans allow us to look at the coronary artery disease with a contrast that is injected just through the vein. So nothing, it's no longer, an interventional procedure is no longer required in order to look at the coronary arteries.
Okay, and let's move on over to, I know this is one of your specialties, Dr. Malaisri. I've spoke to a lot of your patients with aneurysms. Tom asks, I'm 74, had a mechanical AVR aortic valve replacement all the way back in 97. Now I have a 5 centimeter aneurysm. I keep my INR 90% of the time. I'm in good health. Should I get a tissue valve to replace the mechanical valve?
Well, this patient has done so well with the mechanical valve, and since 1997, I count 28 years with a mechanical valve with no problems. And that's the key point. If you have a mechanical valve, you never had bleeding issues, no stroke in the past, no embolisms to the legs, for instance, like the valve has served you very well, then I see no reason to replace the mechanical valve. We can just replace the aneurysm at the same time. On the other hand, some patients have trouble keeping their INR in range. They've been admitted for bleeding. They've had a stroke in the past. This does represent an opportunity for us to replace the mechanical valve and give you a tissue valve and free you from the burdens of Coumadin. So it is very patient dependent.
Got it. And we're going to go real time to Paul, who asked the question on this topic of aneurysms. Can someone with a dissected descending aorta receive a new aortic valve using a TAVR procedure?
Yes, they can. So a type B dissection involves just the descending aorta. It doesn't involve the ascending aorta or the aortic valve. And I think the question relates to a chronic dissection. So maybe the patient has had the acute dissection in the past and now is living with a chronic dissection. will that dissection interfere with delivery of the transcatheter valve? It does not, but we will take a very close look at the anatomy that you do have, because there are certain situations where we would avoid going up through the groin, which is a normal delivery path for TAVR.
Great. Now let's move over to something that I know we are all concerned about, which is, I know I was before surgery, is this notion of how well my heart is pumping and the ejection fraction. We got a question from Evan who asks, Adam, before SAVR, I had a 52 ejection fraction. A 27 millimeter bovine Edwards valve was installed. That was 4 years ago. My last echo in January showed a 53 ejection fraction, which is the low end of acceptable. I would have expected higher. Is this a normal situation?
Well, this goes back to what the status of the heart was before the valve surgery. So if we caught this aortic stenosis, I'm assuming a little bit later, then the valve may be irreversibly damaged. For instance, the heart function cannot recover afterwards, or scarring in the myocardial in the heart muscle itself. So in those cases, the aortic valve replacement will halt the damage that has already been done. So we wouldn't expect the function to get better. However, we get to it early enough and the heart function is reversible, then we would expect the ejection fraction to get better. Now, I'll tell you, at 53% ejection fraction, I would expect Evan to be living a normal life with full capacity to do a full range of physical exercise. I'd be surprised if he said he wasn't.
Great. And moving on to this set of questions, Dr. Malaisary, is about multiple valve surgery. And Joyce has a great question. She's going to be 82 in July. She's got AS and sclerosis, mitral regurgitation, tricuspid regurgitation. All are moderate. I wanted to ask Dr. Malaisary if these valves can be treated with a minimally invasive procedure and what he would recommend. I also want to know if TAVR, MitraClip to repair the mitral valve, TriClip TER to repair the tricuspid valve might also be an option. My final question is, do I have to wait until my valve disease becomes severe before being treated?
Yeah, this is a case where all the options are available to her. And I would be very careful to look at the indication for any intervention. So before we think about what type of intervention, we think about, does the patient need an intervention at all? Because sometimes medical therapy, we've got great drugs to treat heart failure and actually improves function of some of these valves. So that's the first question. Usually patients with moderate disease do not require any intervention at the time. The question becomes, well, what about multiple valves? We just don't know that. I think the combination of aortic and mitral may be reasonable to treat that, especially if the patient is having symptoms. But if the patient is asymptomatic, I think you definitely have time to think about it. All the options are available to you. One benefit of open heart surgery is that all valves can be repaired at the same time. If you decide for a transcatheter approach, we typically space these out. So you have 3 valve problems. We will probably do that in 3 different procedures.
Great. And now more questions about TAVR are coming in. We're going to have some follow-ups real time. From Greg Egan, he asks, question regarding transcatheter aortic valve replacement. Is TAVR resilient under intense exercise? Does one require anti-rejection or blood thinning drugs to maintain its proper performance as an artificial valve?
Yeah, yes, the valve is resilient under exercise. The testing that is done in the laboratory is very rigorous, meaning that they put it in the machine and it goes through over 1 million heart cycles, and these valves can definitely take on the blood pressure that you would get during exercise. So if you have a good TAVR or AVR, and I see no reason that you shouldn't go back to your normal activities. Now, the issue of blood thinners, so anticoagulation, so Coumadin or one of the DOACs, is that required after tissue valves? Typically, they are not required after tissue valves, but a lot of patients need anticoagulation anyway, specifically atrial fibrillation. So if you don't have atrial fibrillation coming in, there's a chance that you're going to develop atrial fibrillation sometime later in your life. So that is a big consideration, because if you're already on Coumadin for another reason, mechanical valves should come into the discussion.
Great points. And moving on, one more question. We get these a lot, talking about the reoperations, which you have touched on, Dr. Malasry, and most importantly, the lifetime management of valve disease. Shirley asks, I'm planning for a future redo of my aortic valve, which is a cow valve. What is the latest research showing for getting a surgical valve or a TAVR in the original valve? And I think she's talking about the durability of the valve and valve.
Yeah, and we've led studies on valve and valve procedures for patients with low intermediate risk, and publications are forthcoming. I think the valve and valve operation after surgery, surgical aortic valve replacement, can be very safe, very, very safe. So we're talking about less than 1% risk to your life. The caveat is that we have to select patients very carefully. That means we have to take a close look at the CT scan of your heart and your surgical valve and see if the new transcatheter valve is going to fit in there and avoid complications with other structures inside the heart. The important thing that Shirley should know is before you go to your doctor is to find out what surgical valve you have in your body right now. Usually the company will give you a valve card. You should have that handy because we won't remember you won't remember what valve you had, and we need to know everything about that valve, not just the make, the model, but also the size.
Yeah, and so this is a real-time question coming in from Susan, Dr. Malasry, about what you're talking about. She says, can you comment on a third aortic valve replacement? Seems like she's maybe already had two surgical valve replacements because she asks, I've been told that my current valve is too small for TAVR. Can you talk about that?
Boy, so it sounds like a patient has had maybe an aortic valve replacement and also a valve and valve and may need a third valve inside the body. Well, you can imagine that this case becomes more and more difficult because with each transcatheter case, more valves get stacked on each other. We cannot take any old valves out with a transcatheter procedure. If you want the old valves out, that would require open heart surgery. Now, there's some cases where patients just will not tolerate open heart surgery. And yes, cases have been done with valve in valve in valve. So that case is feasible. It's going to take a lot of planning.
Got it. And so let's go on to the next question. We are going to bring the robot into this and robotic assisted procedures. Jim asks, hello, I had a mitral valve repair with a Corsum Memo 3D mitral annular ring and tricuspid repair in March 2018 via Da Vinci robot. How long do these repairs last? And what should I do or not do to prolong their effectiveness?
With a good mitral valve repair, assuming it's for mitral valve prolapse, we expect over 90% durability out to 10 years. So I think you're going to have a very good outcome with mitral valve repair, tricuspid valve repair with a robot. And we always recommend a heart-healthy diet, just like everyone else in our population. You take care of your weight, make sure you don't have diabetes, avoid a sedentary lifestyle, and check your lipids. So everything that you would do normally to maintain a healthy heart that will maximize your longevity.
Got it. And earlier you were talking, and this is going real time, Dr. Malasry, to a question from Tina. You talked about recovery from cardiac surgery. Tina is asking, was the 3-day discharge, was that for SAVR or for TAVR?
Yeah, that was for SAVR. So that was with open heart surgery. And TAVR also has about a 2 to 3 average length of stay after the TAVR procedure. So we can get pretty close with open heart surgery, especially with minimally invasive cardiac surgery. We expect about a 3 to 5, but TAVR is the shortest length of stay at about maybe 2 to 3 days.
Got it. And we're going to go real time again. We're getting some great questions. This one comes in from Natalie. I've never heard this question before. Is the Ross procedure an option for reoperative surgery after a Bentall procedure?
It is. So Ross procedures can be done for patients with failing valves. About 10 to 20% of our Ross patients are reoperative surgery. It does make the operation more complex. It takes longer to do. It takes a little more careful planning. But the Ross procedure, as long as your pulmonary valve is okay, can be an option for a aortic valve disease, whether it's reoperation or not.
Great. Let's move on to another disease that patients in our community suffer from, which is endocarditis. Beverly asks, I had endocarditis in 2024, which destroyed my mitral valve. Had a complete replacement in October. The infection was never identified. I was administered 6 weeks of IV antibiotics after surgery. How likely is it that I will get this again with my tissue valve replacement?
And this is an excellent question. Sometimes we just cannot find the bacteria on culture, so we treat that with broad spectrum antibiotics. That's why you got IV antibiotics at home. That's a big deal. So it's not oral drugs. You have to have an IV at home and get administered for 6 weeks. That's all in the efforts to reduce the risk of reinfection of your valve that you have in place. Now, the estimates range anywhere from risk of 5 to 15% risk of reinfection of the valve through no fault of yours, but there's things that you can do to minimize that risk. Since you do have a valve prosthesis, you have to let all your doctors know that you have an artificial valve. They should know already. But what we'll do in those cases is to give you preventive antibiotics during any elective procedures that you get. So for instance, you see the dentist, let the dentist know that you've got a artificial heart valve, and then they will prescribe antibiotics at the time of your dental procedure.
Great. And this question, Dr. Malaysia, we're going real time, is from actually your patient. Steve Fauntleroy says, Adam, I'm actually an AVR patient of Dr. Malaysia. I had it done back in 2016 and doing just super. I'm thinking about what to do when my bovine valve wears out. What's his perspective on timing for a TAVR?
Well, we look at the valve function for sure. We monitor symptoms. We should be monitoring your valve with annual echocardiograms. If not, the stethoscope by a cardiologist does just fine, in my opinion. Watching for symptoms. Now, I think that the longevity of your valve should last well 10 to 15 years. That's the estimate for our patients. And you have to remember when we say 10 to 15-year valve, well, what does that mean? That means that half the patients will need a reoperation by that time. So conversely, that means that half the patients are doing A-OK at 10 to 15 years. And we've certainly seen tissue valve last into 20-year, 30-year ranges. We can't guarantee it, but there's a chance that your tissue valve can last longer than the 10 to 15 years that we're talking about.
Got it. And here's a great, this isn't a question, Dr. Malaysia, it's a comment from Laura Larkner, who says, 1 year ago today, Dr. Malaysia replaced my aortic valve with minimally invasive surgery. I'm doing great, very active, very grateful. Just sending this along to say thank you. So on behalf of Laura, thank you so much, Dr. Malaysia. Let's move over. We still have a couple really great questions. This is interesting. Getting back to that whole thing about waiting, Dr. Malaysia. Doris asks, I have 4 problematic valves and coronary artery disease. Is it possible that waiting can result in further damage to the heart?
Well, this certainly sounds like a heavy burden of valve and cardiac disease. And yes, I think that even in asymptomatic patients that the heart can undergo damage even before the patient has symptoms. And for this patient, there's 5 reasons that the heart can get damaged. So for you, Luis, I think imaging is going to be key to timing for any sort of intervention. Echocardiograms, MRIs look at the function of the heart very, very well. And it's going to be incumbent upon you and your cardiologist to determine when is the right time to intervene.
Got it. And one question, this one actually comes from me, Dr. Malaysia. You see a lot of valve patients. Earlier, I think it was mentioned the average by STS for therapies on mitral valves by cardiac surgery is only about 5 per year. I'm curious to know about how many valve procedures do you do annually?
I do 150 valve procedures per year.
Okay, so a lot more than the average cardiac surgeon. My question would just be, and I'm sure patients on the line are wondering this, what does Dr. Malazri think is the biggest potential pitfall for patients about to have heart valve surgery?
The biggest one, and I see this fairly often, is to have a preconception of the therapy that you need before you actually see the cardiologist or cardiac surgeon. Now, remember, there's a menu of options that we can offer you: open heart surgery, transcatheter options, minimally invasive, full sternotomy, Ross procedures, valve repairs. All these are available to you. But if you go in thinking that you just need this one procedure, then it takes everything off the table. You should have an open mind when you go see your cardiologist, cardiac surgeon about what is the best procedure for you.
Great. Well, and on that note, I want to go ahead and conclude the webinar, but please don't hang up yet. On behalf of all the patients at Heart Valve Surgery, I want to thank you, Dr. Malazri, for taking time away from your practice, taking time away from the Rocky Mountain Heart Valve Symposium that you're attending right now. Cannot thank you enough for the dedication and the commitment to your patients in helping them get the best procedure at the right time to help them recover as fast as possible. Thank you so much for being with us today.
Thank you very much.
Yeah, and on behalf of myself and all the people in the community, I want to thank the patients on the line. This is a community event. When we get together, we learn, we support, and we educate each other. This is a critical component of our health, and I just want to thank you for being on the line today. And now I also want to do is thank you for completing the survey that's going to appear on your screen. If you could please just take 2 or 3 minutes and complete that, I would really appreciate it. So thanks again, Dr. Malazri. Thanks to everybody on the line. As we always say here, keep on ticking. Thanks so much, everybody. Bye-bye. Hi, everybody. It's Adam. I hope you enjoyed that video. And don't forget, you can always subscribe to our YouTube channel, watch the next 2 educational videos coming up on your screen, or click the blue button to visit HeartValveSurgery.com.